Okay. So I was just going to kind of kick off, and this is just going to be kind of a roundtable, so you can have questions and things later. But I was just going to kick off by talking a little bit about collaboration and the importance of that for sustainability. One of the real key benefits of telemedicine, really kind of core reasons for its existence, is the ability to collaborate with outside sites. It doesn't do you any good if you don't have anybody on the other end of the line. But another benefit of that is, besides just the actual services you receive, is that it's a real key to sustaining your program, your network, all these kinds of costs that are incurred by trying to create a telemedicine program. And so I'm just going to kind of talk a little bit about how we've gone about creating a collaborative kind of environment for our telemedicine network and how is going to help us sustain things. By turning off my slides. There we go. And so in 2006, UAMS, working with a lot of partners, formed what we call the ATOM kind of loose affiliation. It's Arkansas Telehealth Oversight and Management is what that stands for. And so it's governed by a board of directors, which consists of UAMS and Baptist Health, Department of Health, and also two smaller hospitals, which currently are DeQueen and Magnolia. And so we've got hospitals from really all around the state involved in helping form the direction of our telemedicine network. And then besides that kind of smaller governing board, we also have an advisory committee, which consists of a lot of people throughout the state. A lot of organizations are represented there, and you can see kind of just a small sampling of types of sites that are involved here. We've got just about all the hospitals in the state, got community health centers, rural health clinics, et cetera, et cetera. And so the real impetus for this structure was that we wanted to apply for this pilot project that the Federal Communications Commission, FCC, had instigated, which was going to cover 85% of broadband costs for rural healthcare entities. And so in order to apply for that and try to get a robust network built around that, we worked with all these partners to create this ATOM board. And then after the Commerce Department came out with BTOP, we were able to leverage that kind of existing infrastructure and make a really strong case, like Dr. North was talking about. Once you kind of have that initial infrastructure, it's easier to build upon it. And so we were able to build the BTOP project off of that already existing structure. And so you can see now we've got well over 450 sites throughout the state, and every single county has at least one site because we have the health department, county offices have been involved. And so we've got this very robust, very inclusive network that incorporates a lot of different types of sites, not just hospitals, not just clinics. And so this kind of collaboration is important now to get further funding. And so as an example, I'm just going to talk today about the FCC Healthcare Connect now starting. Fund.
All attendees
the FCC, kind of building on their pilot project, has now created this program which is going to be ongoing as far as they know. They've set aside $400 million already for broadband, and not just broadband, they also will cover network costs and things like that, management costs. And the key to it is that it's designed for rural locations. So an individual site can apply for these funds and get 65% of their costs covered by FCC. But that site has to be a rural site as defined by FCC, and they have to fill out a lot of paperwork and do all the know all the rules and regs of the FCC. However, if you form a consortium, then the FCC recognizes that, it's important to have both urban and rural sites to form a really robust, healthy network. So as part of a consortium, urban sites can apply for this funding. The stipulation is that you have to have more than 50% of your sites have to be rural. And so by collaborating with other sites now, it opens this funding to a lot more sites than would be eligible otherwise if they were just all going out on their own. Another nice benefit, of course, is that you can have just one consortium leader that can be in charge of dealing with all the hassles of getting all the bureaucratic stuff taken care of, all the paperwork, all that. All the sites can just contribute a little bit of money and do it once, rather than having 400-something sites trying to do the same paperwork and dealing with all the same bureaucratic rules. And also the back-end equipment, all the scheduling software and switches and routers and all that kind of thing. It's also eligible for some of the cost to be offset by the FCC, but again, why have 400 and something sites all having to invest in these huge infrastructure, expenses, when you can collaborate and have kind of one big consortium that's sharing these costs through kind of just a smaller fee than they would have to pay otherwise. So kind of just an example of the importance of collaborating in terms of getting more funding and sustaining your network for the long term. And so next, Roy is going to talk about kind of diversifying revenue streams and things like that. And he's currently the business administrator for the Center for Distance Health and develops and oversees the day-to-day administration of the center, training and technical assistance, programs, grants, and assists with negotiations of contracts, including the development of new business proposals, affiliation agreements, memorandums of understanding, and preparation of cost analysis and financial impact. So he's kind of our big money guy. So, it's up to you, Roy.
Thank you, David. Thank you all for staying this evening. I was thinking that most of you all be gone by now. It's pretty outside, but
I would be if I weren't going to be up here.
But thank you. Anyway, as Tina Ford stated earlier, we all three work collaboratively together to come up with sustainability models and find ways and mechanisms to sustain the network. Here is a snapshot of our network as it currently exists. It's a lot of stuff on that network, but the main point that I'm trying to get across here, that this network as it exists currently right here probably entails about $8 million. The warranty for the equipment just associated with this infrastructure of this network, that's just the infrastructure, that's not the endpoints, it's probably $2 million a year. So once you build it, then you have to pay for it. That's the bad thing. Some lessons we learned with all expansions, it comes to growing pains and the barriers. You have to secure funding for the sustainability. Sustainability involves increasing personnel, increasing the infrastructure, the maintenance on the equipment, the training, the education, the healthcare providers, etc. Contracts. So one way that we had to devise to sustain our network is we had to develop contracts. There's type of contracts, fee for service, and service contracts. We focused a lot on service contracts. What we decided to do is we looked at our infrastructure and said, how can we utilize and economize our infrastructure and sustain it? And we looked at ways to sustain it by creating mechanisms for network access, where people have to pay us clinical membership or educational memberships. We come up with ways that where we can lease equipment to endpoints or entities that can't afford the equipment. We had add-on packages where people could pay us for usage reports that come across our network if they want to connect peripherals to our network. And we also have this training center. People from all over world coming to the Center for Distance Health Training Center, and we charge them for our intellectual property. They can come in for a half a day, a full day, or 2 full day service, and we cater our presentation to their needs. If they want to learn about telemedicine as a whole, if they want to learn about the Arkansas Angels program or the Arkansas SAGE programs, then we cater our presentation. Billing and claims. This is a huge thing that's constantly changing. The rules are changing, but if you're going to bill for telemedicine, you have to use specific codes and modifiers, and each provider reimburses at different rates for telemedicine. Most providers will reimburse for ultrasound readings because the interpretation can be read remotely, but the providers that we know about that reimburse for telemedicine services at this time are Medicare, Medicaid, Qual Choice, United Healthcare, some plans, and multi-plan, some plans. If you can get some type of philanthropic contribution, that is a great way to sustain your network. If someone wants to donate money for equipment to be placed in a remote site because they had a baby that was born there and it was high risk, or it was a preemie and they want to put equipment out in a remote site, or they want to give money to you for the daily operations to support the network, that are great ways to fund your network and to sustain the network. It's kind of hard to find, and in UMS we have to follow the rules because the institution wants the philanthropy, and so it's a challenge. We leverage our technology. By leveraging the technology that you have, you can decrease your travel and administrative costs by holding meetings using interactive video equipment. Decreasing the travel, that's a cost saving that can be equated to your network, creating opportunities to develop new service lines and products, and educational opportunities such as CME, CNE. Grant funding. I've heard a lot of people speak about grant funding throughout the day and how the grants are drying up, and it's true, but if you can find grants and if you can secure grants, that's one great way of developing, starting your network. I think Mississippi stated that their sustainability plan is not built on any grant funding because it's drying up completely, so they have to build their sustainability model around fee-for-service and contracts. But if you can find grants, it can help boost your program. The ideal type of grant funding is for pilot programs, program expansion, research programs. Some examples of grant opportunities is the rural health, the Delta Services Rural Health Development, Small Hospital Improvement Grants, the United States Department of Agriculture, the Broadband Loan Program, the Distance Learning and Telecommunications Program. Any type of grant funding that you can get, if you have the resources, you need to go after it, because again, that is the best source, and most successful programs started with some type of seed money. They got huge grants that were able to put in the infrastructure to allow them to get started. But again, once you get this funding, once you build it, yes, they will come, but you have to keep them coming, and you have to learn how to sustain your program. When you're going for grant sources, you have to be unique. Remember, a telemedicine-based program does not necessarily need a telemedicine-based grant. Incorporating telemedicine into a regular grant opportunity would add innovation and may attract attention of the reviewers. So a lot of times when we go for a grant, it may not be telemedicine-based, but we put a telemedicine-based spin on the grant, which makes it more palatable and give us more credibility because we have this huge infrastructure in place, so we add that as a source. Tina Benton is now going to come up and talk about healthcare avoidance. Tina Benton is the Program Director of Angels, which stands for Antenatal and Neonatal Guidelines and Education Learning System, in the Department of Obstetrics and Gynecology. She's also the Clinical Division Director and Operations Manager of the Center for Distance Health. Benton assists assisted in the development of the Angels in 2003. After 12 years of service in the Department of OB/GYN, along with UAMS, Ann Bynum and Tina Benton accepted the American Telemedicine Association's Innovation Award for the Angels program in 2007. The Center for Distant Health acts as an expert consultant and advocate to develop creative telemedicine initiatives in all areas of healthcare delivery. Tina Benton, which is not on her bio, I have worked closely with her for years, and she always has been the mother, the nurturer, the giving person, the hands-on, the loving person that wants to save the world. And when I first came to Center for Distance Health, we kind of clashed because she was wanting to give it away free, and I say, no, we need to charge for it. And then we would come to a medium and say, okay, we come to the middle, but I personally know her, and she's just a caring person. If you don't remember anything else about her, remember that part.
So you know I had trouble with this one. So actually I had like 15 slides, now I have 4. And the reason I did that is because the ones that I'm going to talk to you about are really concrete. We know that they are healthcare avoidance, and so that's where I'm going to go with this. So in Arkansas, what we're looking at now, our whole paradigm of health care is going back to patient-centered healthcare. And even the language in the Arkansas, the healthcare initiatives through DHS, it's, some of the language is the same thing that I'm saying here. And it's a good thing. Certainly for clinicians, we all have the passion to embrace patients no matter where they're at, and certainly that's part of my career. So improving the health care of the population is certainly something that you need to look at in your state, and enhancing the patient experience of care. A lot of times we forget about that because we're so busy doing blood pressures and documenting in the new EMR that we don't know how to navigate yet, and also making sure that we are dotting our I's and crossing our T's and making sure we're not missing anything. We all focus on quality as a clinician, and we want access for patients, which telemedicine, of course, brings to the table, and reliability. And reducing or controlling cost of health care, of course, is the big thing. So how do we do it? And there's not a one-stop shop. And so some of these things that I'm going to talk to you, there is true documentation that they do help. So subspecialty healthcare access, it does reduce patients' travel costs, for sure. It promotes best practices because there are subspecialty. The knowledge base and the intellectual property is, if you were here with Dr. Lowry, I'm sure that he told you that message, but there is some enhancement with subspecialty access and care. Save time from work. A lot of our patients that live, 200 miles away and come to, for OB, they come to our high-risk clinic, and, it takes a significant amount of time and effort to get there. And now they may go 5-10 miles down the road, get their high-risk ultrasound and consultation with their genetics counselor, and our APN gives them information, and then we call the physician, the primary OB in their community, and tell them what they need to do, what their recommendations are. So we shorten their work time away from work time. I think there is increased patient satisfaction if they can get all that 5 miles down the road instead of 200. And primary care provider support. And I really do believe that subspecialty does enhance the primary provider. I know that I was the liaison for high-risk OB, maternal fetal medicine services in Arkansas for 15 years. I had private physicians, OBs, family practice, APNs call me every day, many times a day, and ask me about a patient they had in the office. And so for me, that was my driving force to get into telemedicine. And they wanted to ask me a question about a patient that had increased blood pressure, or they had dipped them and they had glycosuria, but they really didn't, have any other symptoms. There's minute things, but they wanted my knowledge base. Really, they already knew what it was, but they wanted to hear it from our end so that, okay, I'm okay, this is the right thing to do. And that is very valuable for those that are in the ditches, in the trenches, out there in the state, taking care of these patients. So it's very important. As far as telemedicine used for hospital cost avoidance, here are some things that I really, really think that can happen. And most of them are ED related, emergency department. In our state, we have mental health support, and sometimes they may cover 4 or 5 counties. And so there's a patient that presents that has attempted suicide. And for the hospital, they are deemed to have to watch them for a certain period of time. And they have to watch them intensely. So in our state, they go to the ICU, which is the highest cost place that there is in the hospital. And so if we have the mental health providers, if they come in, beam in, because a lot of our mental health clinics have the capability of telemedicine, if they beam in and they assess that patient, and if it is a true suicide attempt and there is danger for that patient, yes, admit them to the ICU, let us watch them. Let's bring some resources to that patient. But if it's a gesture, or if it was probably not, and 9 times out of 10, that can happen, and you can let them go home. Of course, there's some follow-up and things that need to happen, but truly, as we've done outreach, this is one of the biggest things that hospitals have, and it's a burden on them. And so that's one thing that I think we could do. Remote monitoring. I think we're fixing to do a pilot in our postpartum. We have a lot of sick mothers that we deliver. And so we're going to do some remote monitoring, blood pressure, weight, things like that, starting in July. And we have one project we're going to do. It's our postpartum patients that have been preeclamptic or eclamptic. They have significant blood pressure problems after they deliver the baby, and we keep them in the hospital to monitor that. And so we are going to do a pilot project, send them home with remote monitoring. It will have video capabilities. We can talk to them. We can check their blood pressure every 4 hours and just monitor them and intervene appropriately if we needed to. So I think that's going to be a good thing for those kind of conditions, chronic disease conditions such as COPD, congestive heart failure. I do see benefit and cost avoidance in those. I do think that nursing homes in Arkansas, most of the nursing home patients eventually get on Medicaid. And unfortunately, when they hit the emergency room, Medicare picks in. So there's a paradigm there that nobody really cares, because the nursing home pays through one revenue stream, and then when they hit the ED, it's another revenue stream. And so it creates a point where nobody's really doing anything about that. But unfortunately, a lot of these nursing home patients, you have to have an ambulance. It's usually significant pain and disarray because a lot of them are very frail and fragile, and you're moving them to the ED for maybe something that maybe they shouldn't be moved to. So I think that there is I think that there's something that we can do there, and I think it will be cost avoidance where even the ED physician could beam into the nursing home, have a pre-evaluation, and assess that patient where they're at without moving them, and move them forward or backwards as needed. I think that would be a true cost avoidance. And something that we are doing now is, and this is sort of an overlay of our stroke program, is transporting burns. A burn is not a burn is not a burn. And I personally had experience with this. My father, who was 86 years old, had a significant burn on his calf. And we went to our local emergency room, and I used the Center for Distance Health Arkansas Stroke Saves program interactive video, beamed into the burn unit. We only have one burn unit, and it's at our children's hospital. And they looked at it because I thought he was going to die. You know, of course, he was my dad. And they told us how to clean it, wrap it, and they'd see us in the morning. And so he didn't have an ambulance visit. He didn't, we actually deferred that. So in burns, yes, it's a great assessment tool. Trauma, it's a great assessment tool, and it can also start care where they're at. And I think that that can be a cost avoidance. Some of our programs that we have in place now, of course, is our stroke program. It is enormously cost savings, but also you get such good quality, and you are intervening in places on strokes so that they actually get TPA, the clot-busting drug. And what that does for non-clinicians, that means you may not go to the nursing home after that big stroke. You may get to go home and garden and do what you normally did. You may be able to talk. You may be able to move like you normally do. So it's a big deal, and it's a cost avoidance if there's accessibility for that clot-busting drug. And you got to have neurologists, you got to have CT capability and labs, and interactive video. And 40 of our 86 hospitals in Arkansas are part of this program, and we're very proud of that. And I think we're going to probably go up maybe 3 more, and then we'll go into maintenance, because that will mean that most citizens in Arkansas will have a 30-minute to 45-minute access to any of these hospitals for stroke. The other thing that we do, and I'm sure everybody's talked about, is the image repository. And certainly I know for sure in my experience, even in OB, how many ultrasounds that have been duplicated and duplicated and reduplicated. The same thing when you have patients that go from one hospital to the next. They may have a CT scan, they may have an x-ray, they may have done all these things. And then you go and they're moved to a higher acuity hospital, and all of that's lost. And then you restart from scratch and re-CT, re-x-ray, re-lab. And so image repository can help push images back and forth between institutions so that you can share that. And we don't, number one, expose patients to more radiation, but also it's a cost saving because you're not duplicating services. Very important. And I think that we have to consider some more and more things, even labs and things like that we can share across. And electronic medical record, of course, will help that. One thing that we're working on, and certainly this is an interesting paradigm, is the prison and jail. We have angels, I say we. OB has been into the prisons. We do care there. And so now we're exploring opportunities in cardiology, orthopedics, emergency access, things like that. They experience different paradigm of things, but I think it's interesting enough to talk about. And you know, they have high cost of transports. When you move a prisoner from one place to another, you have the driver and then you have the guard. So that's a lot of FTE time that's bound up on one patient. And so what you can do if you have telemedicine within the prisons and the jails is to pre-evaluate them from the prison. And certainly I think that that's going to be a big cost avoidance because, number one, we pay for these anyway, so let's do it in a better way. We all pay. The other thing is provide specialty care. There's a lot of chronic disease. There's prisoners in there that have been there for long periods of time and have, just the aging, chronic disease kind of initiatives. And instead of bringing them all out, we can bring specialty care in there and do post-op follow-ups in eye and any kind of surgery, things like that they have at the hospitals. Of course, you can do telemedicine and check their wounds, all those kind of things remotely via telemedicine. Very much cost avoidance. So those are short things. I think that what we have to do when everybody's different, you have to kind of think about what the value of it is and how you can move it, how you can, and big picture things. For us, OB, and we have 20 sites across Arkansas to have access for high-risk OB care to all of the pregnant women that need it. As far as cost avoidance, I'm not so sure unless you look at outcomes. When you look at outcomes and you distribute up women to a higher level of care that need it, and then push the women back to the OB providers, because they may need one visit with us, or they may need 10 and be delivered there. That is a cost avoidance too. So think about what you want to do, and just kind of do a pro forma and assess all the way around. And Steve North, who's in the audience, also said, be sure you know what your community needs are and wants, and they also have to have desire there. You have to have it on both ends, or it will not work. So I thank you, and it's short and sweet. If you have any questions, we'll be happy to entertain them. Thanks.
I think we've got a good 15, 20 minutes for questions, so please.
Are there marketing strategies that you're using to make the population more comfortable using the telemedicine services? Like billboards, Facebook, anything like that?
Yes, and yes. In the stroke, when we started the stroke program, and the former director of that, she was very innovative about, so each community hospital that was a stroke partner, it was all about them. And even we had billboards, radio announcements at every community hospital that was a stroke site, an RSAFE site. And when that happened, it was them. It was their community. It was their stroke program. It was not UAMS coming in with their vascular neurologists. It wasn't about them. It was about the community. The other thing that we still do in the stroke program is a huge community and marketing. So we have health educators that go into the schools, to the senior adult centers, to any kind of community function there to talk about it, because with stroke, you have to get to the hospital in time for the clot-busting drug. So we did a huge campaign, and we still do. Mm-hmm.
Yeah, and I don't have the actual specific data with me, but we have shown through some of our RSAFE's data that the number of people that come in early enough to be able to take advantage of that TPA, that clot-busting drug, mm-hmm. has increased as the program has gone on. So that there's indications that community outreach has really made an impact in those communities where we have these programs.
I have a question about the pilot program you mentioned. I think you said you're going to be starting at pre-funding.
Yes.
I just want to hear a little bit more about that. Will you have certain parameters around the gestational age, and if you let them go, like is it 28 weeks, and they not go 3 or 4 hours away? Or?
Well, basically, it will be after delivery. So it will be postpartum. And so a lot of times, because we see them, we're engaged with them constantly during the pregnancy. And then in the postpartum phase, a lot of them have residual hypertension. Sometimes it goes away, sometimes it doesn't. And the other thing is they are asymptomatic sitting in the hospital, wanting to go home, get acclimated with their baby and to a routine. And so this is a way for them to do that. So it's really postpartum that we're going to focus on. Now, we do have a small program. It's going to be another project. We have it's called CAMP. And what that is mothers that kind of live far away, and they really need to be close to the hospital. And so we put them in a motel down, and so we communicate with them through our 24/7 call center. We have, OB nurses that are 24/7 in our program. And so they interface with them. We actually even coordinate their meals, everything, and even make arrangements for them into the clinic. So we talk to them intimately, and this tool is going to enhance that because it'll be, we can get more live information, blood pressures, blood sugars, things like that.
And your finance guy likes that because like at our hospital, we talked about before, they just sit there in the hospital in a room for 4 to 6 weeks.
Mm-hmm.
We talked about the fact that they actually could be in a recovery post-op.
Yes, and we have been doing that. Another pilot that we're going to be doing is on our congestive heart failure patients, and we're actually, we have about 90 sick congestive heart failure patients over 4 different departments within the College of Medicine that we take care of. And so, of course, in readmission rates, you get kind of dinged on. So if there were ways that we can manage those patients in a more real-time manner, assess them, quickly, and intervene where they don't get to that tipping point where they need to come back and be readmitted, then financially that makes us a little bit more physically stable, but also it's a better outcome for them because they're not getting to that point of really being bad sick. And so we are going to integrate a call number where those patients that meet that criteria of the very sick of those congestive heart failure patients, and they're going to be able to call. We'll triage them. We'll get access to their physicians if they need interventions and get them rapidly elevated within the system and take care of their need quickly so that we can maintain their quality of health better. Mm-hmm.
Okay. Well, Tina, I have a question for you. I know I work with you every day, but I've been saving it up for this conference. So I was actually just kind of thinking in terms of other people who don't have, our program or you available to them. I think one thing that, it's always, you have a lot of expertise in terms of knowing how it's all going to kind of fit together and how it's going to fit in the healthcare community and up there at the distant end and our end and things like that. And I was just thinking, if someone was going to try to start up a program and didn't have, you available, what would you recommend? I mean, do you think someone with a lot of clinical experience or more of an IT background? I mean, how would you find somebody who would know how to make those kinds of decisions of how it's going to work?
Well, I think that you have to, number one, have both. Mm-hmm. But you do have to have the clinician driver. You have to have that champion person and that has the desire, wants to do something, but also has strong IT backup support. Right. Certainly when I first started this, I never even knew what a T1 line was in 2003. It took me at least, I would say, and Roy too, it probably took him, it takes you at least a year to even understand in the meetings what they're talking about. And now I feel like, I can see it, I can see the connections and things like that. And that's what IT does, is they can see that vision. And certainly when you're talking to people that don't have that experience, it's very hard for them to visualize. And so it is really, the most important thing is to have somebody that has all that knowledge to sit down with that person that really has the want and desire to do it and educate them. And just to see the picture of what you're trying to do. I think that's the most important thing. Yeah.
Any other questions?
Thank you, guys. Thank you for staying with us. We appreciate it.
Tamara, is there anything I'm supposed to do in terms of evaluations